We are honored to have Dr. Everson here tonight to talk to you about the latest and greatest with treatments. Dr. Everson is one of the most prominent treaters in the country, so we are definitely honored to have him here and take advantage of his expertise. So if you wouldn't mind.
We're going to talk about hepatitis C, and particularly some of this data is a little, doctor-oriented and study-oriented, but I'll try to bring it down to your perspective here. Now, chronic hepatitis C is something a lot of people have lived with for a long time, and one thing we have to realize when we're a patient diagnosed with this is we have to take care of ourselves, not just with the medications to get rid of the hepatitis C, but also with our habits and everything. So maintaining, proper diet, body weight, exercise, and of course, avoiding alcohol is very important in the general things you can do for yourself to help your liver. The direct-acting drugs, the new drugs that we give patients for the hepatitis C are metabolized or processed primarily in the liver. So there we go. Liver's key to this whole condition. That's why when I talk about hepatitis C, I don't just jump into the drug therapy because the liver is still very important to remember and take care of. That's why I always emphasize, avoiding alcohol, taking care of yourself, trying to maintain good body weight, good diet, good exercise program, just general wellness stuff, and avoiding alcohol. Alcohol is a very important theme here because it's very prevalent. A lot of us socially drink alcohol, and alcohol is just prevalent in our society, and some of us have trouble controlling it. We have to get control of that if we're going to get control of our liver disease, not just the hepatitis C. The two things that you have to remember about hepatitis C, the hepatitis stands for liver inflammation, and C is the virus. And the key liver issues for you as a patient with hepatitis C are shown here. You should understand what some of these things are. I'm going to go through them briefly before we get into the treatment, just so that you understand. Some of you may be on transplant lists or be faced with cirrhosis of the liver. And so the first thing you need to understand is the MELD score, what that's all about, how doctors categorize severity of disease by MELD score and Child-Pugh score, what's happening with the assessment of fibrosis in the liver today. In the past we were focused on biopsy. Now FDA just approved FibroScan last year, so we're using that in our clinic to measure fibrosis now. So that's non-invasive ways to assess fibrosis. And then you should understand some of the complications of liver disease, where they're coming from. Why is it that some people develop veins in their esophagus that bleed, or low blood counts, or fluid in the abdomen, or have encephalopathy or mental alterations. So we'll talk a little bit about those things. Your doctors will get blood tests on you, blood tests, blood tests, blood tests. And when they look at the panel of blood tests, what they look at are certain features that relate to the liver. So the first two are ALT and AST. Those are enzymes that are made in your liver. So when the virus invades the liver cell is damaged and these enzymes leak out. And the height of the enzymes is somewhat correlates with how severe the damage is. But it's only the ongoing injury. It doesn't give you a marker of, liver function per se. Now the things that relate to liver function are the INR, which is clotting factors made by the liver, albumin, which is a protein made by your liver that keeps water in your blood vessels and prevents it from going out into tissues. It prevents you from running around with edema and ascites. And then bilirubin is the yellow pigment, and it's actually made from the breakdown of red blood cells, which is naturally occurring in your body all the time. And the bilirubin that's produced from that is taken up and excreted out of the body by the liver. So when the liver's not working, bilirubin builds up and you turn yellow. Jaundice bilirubin is the cause of yellow jaundice. When your liver gets scarred up and you develop increased pressure inside the veins and the abdomen, we call that portal hypertension. I have a lot of patients that come into my clinic and they say, my doctor put me on this drug for hypertension. And I look and it's Nadolol or Propranolol or something like that. Those drugs aren't typically used for regular old blood pressure, but they are used to try to control portal hypertension. So the medicines that used for controlling high blood pressure inside your abdomen are a little different than the ones used to treat standard hypertension. The other thing that happens in the context of trying to develop models or strategies to give you information how ill you are or so on and so forth is we put these laboratory tests and clinical features into models, and we develop these models through clinical trials and so on and so forth. But a lot of these models are online, and you could put your lab tests into the model and it can calculate numbers for you and predict your risk of cirrhosis, and in the case of MELD score, predict your chance to survive in a period of time. And MELD is really for late stage disease, like 90 days. So here's some of the lab scoring systems. You'll see the Hep C model online. It's actually something you can call up online, and you can put your test results in, and it gives you a risk score of the chance you would have cirrhosis if you did have a biopsy. Now this is the model that we use for allocating livers in the United States and also in Europe, and it's called MELD. And this was developed, went into action in about 2002. Prior to that, we were allocating livers to patients, prioritizing candidates mainly by kind of clinical judgment and clinical features, and this has been completely replaced by the MELD score. So you'll see that the MELD score is calculated purely from blood tests, bilirubin value, prothrombin time, creatinine, and this generates a score. There's a formula there, and the score ranges from 6 to 40. When your score is between like 6 and 10, we typically say you're stable, you have what's called compensated cirrhosis, and typically don't need transplant, although occasionally we do see patients, despite having very, very low MELD scores, that can have significant complications of liver disease. But so MELD is imperfect that way. The MELD score 10 to 15 is where we usually evaluate patients for transplant. If you're over 15, we say typically list for transplant, but the fact is that transplants aren't really performed until the MELD score is over 25. And actually today there's a new policy that went into action this year. It's called Share 35. And what's happening is livers are being diverted all over the place to candidates on the waiting list whose score is 35. And what we're seeing is the MELD score at which transplant is being performed today is jumping up higher and higher. And that's why in our system we are emphasizing more and more the need for live donor liver transplantation. Anyway, so there's some MELD score and transplant. Now we also have this score here, which some of you may have heard of this, Child-Pugh score, or Child-Turcotte-Pugh score. And it's got some clinical features like ascites and encephalopathy. Ascites is a fluid in the abdomen. Encephalopathy is a mental change that happens in cirrhosis. And otherwise it has lab tests similar to MELD, except albumin replaces creatinine. This used to be the basis for organ allocation, and MELD's replaced it. It still is used mainly by surgeons to predict your risk for having complications or dying from surgery. So for patients, it's a relevant score because if your score is greater than 7, so you can see the classes down below. CTP class A is a score 5 or 6, CTP class B 7 to 9, CTP class C 10 to 15. So if let's say you were a patient with cirrhosis and you had 1 point in each of those 5 categories, your CTP score is 5, right? And if you had 2 points, it would be 10. If you had 3 points in each of those 5 categories, that's 15. And then there's intermediate scores based on variability in your score, in your lab tests and your clinical features. Anyway, the point of this is that this is another way in which doctors determine how risky surgery is for you. So if you have cirrhosis and you go to the doctor, this is one of the things they may do. It's called the Child-Pugh score. Now, more relevant to all of you is the way we now determine how much scar tissue you have in your liver. The tried and true way was to stick a needle in there and get a chunk of liver out. People don't like that. And no matter how easy it is or how good the technician or the technical person is that's doing it, It's very seldom that someone really says, I really enjoy liver biopsy. So even though it's been the gold standard and it's how we pretty much have in the past quantified the amount of scar tissue in liver, there's sampling error with it, and of course it's inconvenient, risky, and patients don't like it. So the newer techniques are what we call elastography. They're kind of lumped under that. There's many ways to do it. One way is to put the person in an MR machine and determine elastography that way. That's not very practical because it's pretty expensive and you have to schedule it through radiology. Very accurate though in terms of defining how much scar tissue is in the liver. Another technique that was FDA approved in last year was fibroscanning. This is very simple. We have a machine now in our liver clinic at the university, so we see patients in the clinic. If they've not eaten for 3 hours, they can have a fibroscan. You have to have no meal for about 3 hours prior to the scan. This is the approved way it's done. And basically, you lie down on the little bed there, pull up the shirt to here, squeeze a button about 10, 15 times, and which each one of those is a shock wave. And then the shock wave goes to the liver, we measure it, and the speed with which it goes to the liver correlates with how much scar tissue is in the liver. I'll show you that in a second. And then there's some serum markers, blood tests that can get us pretty good results at the high ends and low ends, but haven't been so good for the intermediate zones of fibrosis. Well, this is the liver biopsy. Some of you may have had one of these, where we clean the skin and put the needle in, and there is some bleeding with that, even though generally it's very minor. From the biopsy, we've staged how much scar tissue you have from a stage 0 all the way to 4. Stage 4 is cirrhosis. It's interesting, many years ago, probably about 20 years ago, I put this slide together. This slide has appeared all over the place. You know, I go to meetings and of course I never gave them permission, but I don't say anything about it. But anyway, it's for some reason, it's been around. Anyway, so stage 0 is basically a normal liver, and then as the fibrosis increases, that's the blue stain in there. You can see that the fibrosis can increase quite dramatically, so that stage 4, you get these little nodules. The interesting thing about this slide, there's 5 different patients here. So who had the highest viral load? Betsy, take a guess. Who had the highest viral load? You're going to go low stagers had the highest viral load.
No, I wouldn't say that.
You're going to say the high stage has the highest viral load. The viral load of every single one of these patients is the same. 5 million. Okay, second question. Who had the disease the longest? Typically, you'd say the stage 4. In fact, these 5 patients had the estimated duration of disease the same. So that just shows the variability of this disease, right? So some of you may have been living with Hep C for 20, 30 years and have almost no scarring. And some of you may have lived with Hep C for 15 years and have cirrhosis. So the disease progression is variable. Now, FibroScan does not give you that. FibroScan is measuring the speed of a shock wave through the liver. Now, patients like this, because notice there's no blood, and that device just is painless, and there's no pain to it. It just, you might feel a little vibration. And what you get out of this is this. In the upper right, you'll see that kind of thick black line coming down. That's actually the shock wave that's going through the liver. The x-axis, which is the horizontal axis, is actually the time factor. And then the y-axis, or the vertical axis, that's the distance. So distance divided by time is velocity, right? So if you have a slope that's a very slow slope, that's a slow time, that's a soft liver. Shock wave going through a soft liver is slow moving. And if you have a stiff liver from scarring, then that line is very steep, and that is consistent with cirrhosis. So what you get out of this is the speed of a shock wave through the liver. You don't actually get histology. But from that, we correlate that with fibrosis, and it correlates pretty well, so that if your reading on that's over 12.5, you probably do have cirrhosis. Now, there's confounding factors, of course. Now, you probably heard of FibroTest and FibroSure. These are other ways to non-invasively get an idea of how much scar tissue is in the liver. They work, again, at the extremes. So they're pretty good at detecting who has cirrhosis and pretty good at saying, hey, you don't have hardly any significant scarring, but intermediate stage is not so good. And then you can actually use standard lab tests and generate some information about the risk of significant fibrosis or cirrhosis. So this is an experimental test that we're doing here in Colorado. I'm actually the inventor of this thing. And here's another way that we measure liver function, which is to draw blood. And we administer some test compounds. And we measure the way the liver actually extracts these from the blood. So the graph on the right is a display of how quickly the liver removes these test compounds from the blood. And we can quantify the whole organ function doing this. So that's under investigation. It's not FDA approved. The other things I showed you were FDA approved. So diagnosing cirrhosis, we have these things, and those are the test results that correlate with cirrhosis. Now, why does all this matter? I mean, here I am. You guys didn't come here to hear about cirrhosis and all that. I'm sure you wanted to know, I want to get cured and so on and so forth. So why does it matter? Well, this is why I do harp at patients and doctors and everyone that you do need to still pay attention to your liver, not just the virus. Because those of you who have built up a lot of scar tissue and cirrhosis are at risk for complications, even if we get rid of your Hep C. If we cure your Hep C with these new therapies, you may still have issues with your liver, and you need to be aware of that. And no one's going to, once you're cured of your Hep C, no one's going to remember that. They've got the next patient to treat, the next clinic, You're the one that's got to remember, hey, I do still have significant fibrosis in there. I need some follow-up. And, this is one of the biggest educational thrusts of what I do as a hepatologist, a university hepatologist, is try to educate my colleagues in clinical practice to really focus on diagnosing the stage of fibrosis and cirrhosis in their patients, even when they're assured that they're going to have great chance for cure. Now, and the other thing is you're at risk for liver cancer when you have significant fibrosis or cirrhosis. In the compensated stages of cirrhosis or advanced fibrosis, and that means I've never been in the hospital for my liver, I've never bled from varices, I'm not having fluid retention, I'm thinking clearly, everything's fine, but you have significant fibrosis or cirrhosis, your risk of liver cancer is 2% per year. Well, 2% doesn't seem like a lot, but over 5 years, you're up to 10%, right? So keep these things in mind. And once you start to develop clinical features of cirrhosis with decompensation, your annual risk of having a liver cancer actually increases. Also, the other thing, which is not so relevant with the new therapies, but still the one group of patients that seems to be the most difficult to treat with the new drugs is still the patients with cirrhosis. And even though there's been great breakthroughs there, still this group may need a little bit different approach in terms of therapy. All right, so I won't go into all that or that or that. These are the things we don't want you to have.